Namaste students, today we will be discussing one important case for both undergraduate and postgraduate students which is very common in India, especially in the rural parts of India, that is anemia. Anemia will be kept as a main case for both undergraduates as well as postgraduate students, and today let us discuss in detail about the anemia case, how to take history, what all you have to examine from top to bottom, what are the differential diagnosis, how to investigate, and important treatment for the anemia. Here is a patient by name XX, age about 22 years, and she is a female. Occupation, she is a student and she is from Bangalore. History is given by the patient and it is reliable. Coming to the chief complaint, complaints of tiredness since 3 years. So she says actually tiredness is present since childhood, but that tiredness is increased last since 3 years. That is the chief complaint. That is the only complaint. Usually the complaints in anemia students is the symptoms in anemia is very non-specific. You cannot say that because patient is having this symptom, patient is having anemia. They can have a tiredness, weakness, exertional breathlessness, giddiness, faintness, tinnitus in the ear. So like these non-specific symptoms, anemia patients will come to a doctor. Okay, but no symptom is very specific to anemia. Because they are having this symptom, you can say that this is anemia. Coming to the history of presenting complaint, complaints of tiredness and exertion since 3 years. She also gives history of giddiness and standing for a long time, and she also says giddiness while going outside the hot sun and relieved on taking the rest. So two symptoms she has, tiredness and giddiness. So what are the points in the history we will ask in a case of anemia? I have asked some of the important points negative history in this case. Then I will discuss in the case of anemia pertaining to the iron deficiency anemia, megaloblastic anemia, normocytic normochromic anemia, and in Pancytopenia case and in iron deficiency anemia, what are the points you will ask in pertaining case? Okay, what are the positive and negative symptoms you will ask in the history? I will discuss. Okay, in this patient, some of the points which I have asked in the history is, she says there is no history of dark yellowish coloration of the urine, okay, since childhood. So because she says the symptoms are since childhood, okay, so we have to suspect, okay, probably a genetic inherited anemia like hemolytic anemia, okay, where they'll have a jaundice. But in hemolytic anemia, even though they have a jaundice, yellowish discoloration of the eyes, because it's the indirect bilirubin elevation, that indirect bilirubin won't be excreted in the urine. So urine color won't be yellow color in hemolytic anemia. Same like our patient also says, there is no history of darkish yellowish discoloration of the urine since childhood, because it is the indirect bilirubin which will be elevated in the hemolytic anemia. But she gives history of yellowish discoloration of the eyes, okay, sometimes. So probably whenever she is having a hemolysis at that time, she is developing the indirect bilirubin elevation that is producing the jaundice in her. So she is saying sometimes there is a yellowish discoloration of the eyes, but not the urine. No history of vomiting or abdominal pain. Okay, this history is important because abdominal pain and vomiting, if the hemolytic anemia patients, if they develop cholelithiasis, okay, they can develop abdominal pain and vomiting. And one more thing, in a case of anemia, okay, the abdominal pain is important because chronic abdominal pain, diarrhea and diabetes can be seen in chronic pancreatitis. And in chronic pancreatitis, there will be a trypsin deficiency and calcium deficiency which can produce B12 malabsorption, which can produce a megaloblastic anemia. So abdominal pain history is important pertaining to that. No history of discoloration of the feces or skin. So if there is any obstructive jaundice, she gives history of yellowish discoloration of the eyes. If there is any obstructive jaundice, if the biliary duct is get obstructed, then the stool color will be pale colored because you need stercobilinogen for the stool color to become yellow. So only in obstructive jaundice, stool will be pale colored. But here our patient is not giving any history of discoloration of the feces because probably she is having a hemolysis and hemolytic anemia. She says history of constipation since 10 years may not be related to the present complaint, the present anemia, the history of constipation. It is not related to that. She gives history of leg swelling, notice 10 years and especially while walking, and if she takes rest and it is relieving. She gives history of edema. Probably I feel this physiological edema because she don't have any other symptoms of heart failure like a PND, orthopnea. That symptom she is not giving. Okay, but she says history of ankle swelling is there. Notice since 10 years, especially while walking, and it relieves on taking the rest while keeping the legs up. There is no history of bony pain. So you have to ask history of bony pain because in a acute leukemias, okay, they can have anemia and they can have a bony pain because of the marrow expansion within the bone. Okay, the bony pain, history of bony pain you have to ask. No history of loss of appetite or no history of loss of weight. So this history is important, loss of weight or loss of appetite, because malignancies, see a lung, see a breast, okay, they can go, and prostate carcinoma in a male, they can go and invade the bone marrow producing myelopathic anemia, and they can present with the anemia. So history of loss of appetite, loss of weight is important in this case. No history of blood in the stools, okay, or history of hematemesis. So this history is important, whether they are losing blood from the GI tract, okay. So they can lose blood from the GI tract. So in the upper GI bleeding, the causes like acid peptic disease, esophageal varices, Mallory syndrome, and CS stomach history, which can bleed from upper GI tract, you have to ask. Similarly, from a lower GI tract, they can bleed from hemorrhoids, see a colon, polyps, diverticulosis. So these lower GI, whether they are having these diseases which can produce lower GI bleeding, is there, you have to ask. Another important history in India, especially agriculture country like India, occupation. If their agriculture is the barefoot walking, will produce hookworm infestation, which they can lose the blood in the GI tract. So she gives history of palpitation while walking, climbing and running. Probably she is having a less hemoglobin, that is the reason for her palpitation. A high output state which is producing the palpitation, especially an exertion while walking, climbing and running. She also gives history of excessive sweating. There is no history of cold or hot intolerance. This cold intolerance and even a weight gain history, if it is there, or any facial puffiness history, that is important, okay, because of myxedema. Myxedema can produce a normocytic normochromic anemia. Very rarely it can produce even megaloblastic anemia. So symptoms of hypothyroidism like facial puffiness, history of weight gain, cold intolerance is important. No history of increased micturition during night time. Okay, so initially polyuria can be a feature of a chronic kidney disease in the initial stage. So that is the history of increased micturition during night time important. Chronic kidney disease can present with a normocytic normochromic anemia. So you have to ask the symptoms here. There is no history of bleeding gums. Okay, bleeding gums history is important because acute leukemias, especially monocytic leukemias, can bleed from the gum. Okay, so history of bleeding gums is important in a case of anemia. There is no history of imbalance while walking, and there is no history of burning or tingling sensation in both the upper limb or lower limb. This history is important, okay, because posterior column and peripheral nerve will be involved in a B12, okay, vitamin B12 deficiency. So they'll have peripheral neuropathy symptoms, tingling of the hands, burning sensation in the legs, and imbalance while walking, especially during the night time. So that history is important in any case of anemia. No history of difficulty in swallowing because especially in a middle-aged female like this, in iron deficiency anemia, there will be a postcricidal web formation which can produce dysphagia known as Plummer-Wilson syndrome. So that history of difficulty in swallowing is important in this case. So history of travel to tropic, not relevant in this case because she lives in a tropical country like India, okay. Probably history of diarrhea is important because chronic diarrhea is a manifestation of a tropical sprue or a gluten sensitive celiac sprue where a malabsorption of B12 and folic acid can occur. So history of diarrhea is important in this case. She says she gives history of fever every month in March month, okay, till 10th standard, and history of respiratory tract infections. A hemolytic anemia like thalassemia, so they can develop repeated respiratory tract infection because of the less immunity, okay, they can develop the infection, inanition, so they can develop that. She gives every year, she gets fever in March month. As I told before, there is no history symptom suggestive of hypothyroidism or hypopituitarism. Hypopituitarism, TSH can be a less, which can produce a less thyroxine, which is required for hemoglobin synthesis. So hypopituitarism like hypotension, hypoglycemia, those symptoms are not there, which are suggestive of hypopituitarism, which can reduce the TSH level. No history of pruritus. Pruritus, probably hepatitis, okay. Infectious hepatitis, they can develop aplastic anemia. So that is why the pruritus history may be important in this case of anemia. No history of mass per abdomen because lymphomas, leukemias, they will have huge splenomegaly and hepatomegaly. So where patient may themselves come with a mass per abdomen. So that symptom is important in no history suggestive of mass per abdomen. No facial swelling, as I told before, to rule out symptoms of hypothyroidism. No abdominal distension, fluid accumulation in the abdomen, ascites, especially in a male alcoholic patient. Cirrhosis can develop anemia. There are so many ways cirrhosis can produce anemia, like esophageal varices, hypersplenism, all cause a depression action in the bone marrow, Zeus syndrome because of the hemolysis of the RBCs, okay, and malabsorption of the nutrients on the GI tract. These are the cause of anemia and liver cirrhosis. So you have to ask history of any abdominal distension. No history of visual disturbance. B12 can produce optic neuritis, okay, and even CKD patients can have retinopathy. So history of visual disturbance you can ask. She says she had a fungal infection of the leg during winter season and it relieved with applying the ointment. Probably infection, as I told, common in thalassemia. So she developed infections, fungal infection and fever every year. So as I told before, there is no history of GA loss, no history of melena, and there is no history of losing blood from any other parts of the body in the form of epistaxis, hematuria or hemoptysis. So she is not losing blood from any part of the body in the form of epistaxis, hematuria or hemoptysis. History of abdominal pain, as I told before, to rule out cholelithiasis and chronic pancreatitis, and no history of Raynaud's phenomena, especially in a sickle cell anemia, autoimmune hemolytic anemia, they can have Raynaud's phenomena. So history of Raynaud's phenomena is important. So these are some of the negative history which you are asked in this patient. Now I just want to summarize and tell in each type of anemia what are the points you want to ask in all the anemias. For example, iron deficiency anemia students, it can develop due to a defective intake, number one, or defective absorption from the GI tract. Some duodenum it will be absorbed. For example, if any gastric surgery has been done with the duodenum has been cut, then iron won't be absorbed. Then increased blood loss. For example, they may lose blood from the GI tract, or a female like her fertile period, they can lose blood from the menstruation, so they can lose blood, the menorrhagia. So blood loss. And then increased requirement. Adult male and a postmenopausal female doesn't require any increased requirement, whereas a fertile female like this during pregnancy requires an increased requirement. A growing child requires an increased requirement, and during pubertal time requires an increased requirement. These are the four main causes where iron deficiency can occur. Okay, so one is the decreased intake, decreased absorption, increased loss, and increased requirement. So relevant to pertain into that factors. Suppose if you suspect iron deficiency anemia, these factors you have to ask. In a female, especially menstrual history, we have asked in her menstrual history is normal. I will tell in that when I come back to the menstrual history. So any increased bleeding, menorrhagia, metrorrhagia, you have to ask. During one menstrual period, a female will lose 30 milligram of iron. One menstrual period, a female will lose 30 milligram of iron. Then repeated pregnancies and miscarriage, because pregnancy requires iron. Okay, it is a iron increase requirement condition. So repeated pregnancy means the mother will develop the anemia. Whether she had any repeated pregnancies or miscarriage, you have to ask in a female in the reproductive age. Okay, I am discussing female in the reproductive age. Then diet, like any other category, even if they take less diet, okay, especially iron is more in a non-vegetarian food, green leafy vegetables, okay, a decreased intake in the diet, or GI loss. GI loss can also occur in a female in a reproductive age group. So GI loss symptoms, you have to ask hematemesis, melena, hookworm infestation, those things. Then whether blood is losing from any other part of the body like hematuria, epistaxis, and hemoptysis, you have to ask. Then whether patient has undergone any GI surgery. As I told, duodenum iron is absorbed. So if she has undergone any GI surgery, iron won't be absorbed properly. And whether they are using chronic aspirin injection, you have to ask. This is pertaining to the iron deficiency anemia. Now, that is iron deficiency anemia in a female in a reproductive age group. Iron deficiency anemia in a male and a postmenopausal female. In an adult male and a postmenopausal female, they are not growing. They don't require iron. But unless and proved otherwise, an adult male and a postmenopausal female will develop anemia only if they lose blood from the GI tract. So all those GI tract losing blood conditions you have to ask, which I told, esophageal varices, acid peptic disease, CA stomach, Megaloblastic syndrome, upper GI tract, lower GI tract, CA colon, diverticulosis, polyps, okay, and hemorrhoids. These things you have to ask, and hookworm infestation. Then in a male and postmenopausal female, even GI surgery, and whether they are losing blood from other sources like hematuria, epistaxis, hemoptysis, you have to ask, and diet history and chronic aspirin injection. In iron deficiency anemia, in a third category, like infants and children students, where they are growing and increased requirement is there. For them, you have to ask, a diet history is important, whether they are taking proper diet or whether they are prematurely born. A prematurely born baby will develop iron deficiency anemia. And if the mother is having iron deficiency during pregnancy, the baby will also develop iron deficiency. And whether mother had a multiple birth, which can develop anemia in a child. So, multiple birth history you have to ask. And GI loss, like any other case also, you have to ask in these infants and children whether they are losing blood from GI tract, and any blood loss from the other sources like hematuria, epistaxis, hemoptysis, you have to ask. So, these are the history wise you have to ask in iron deficiency anemia. Now, let us come to the megaloblastic anemia. The race is important, student. In megaloblastic anemia, what race? Religions in the Hindu, they are pure vegetarians. So, megaloblastic anemia will develop in a pure vegetarian food because B12 is present only in non-vegetarian food. Maybe some dairy products like curds, milk, it may present in a very less amount, but mainly present in a non-vegetarian food. So, race is important, religion is important in megaloblastic anemia history. Then, family history. Some of the B12 deficiency can develop, it can run in families, very rare inherited diseases. Okay, let us not go detail into that symptoms. Okay, then CNS symptoms, as I told in B12 deficiency, paresthesia you have to ask, tingling and numbness, and loss of imbalance during night time. That history you have to ask. Then, history of diarrhea. B12 is absorbed in ileum, whereas folic acid is absorbed in jejunum. So, history of diarrhea, like tropical sprue, gluten sensitive enteropathy can have diarrhea. So, history of diarrhea you have to ask in a megaloblastic anemia. Then pregnancy, increased folic acid will be required in pregnancy or a recent delivery. So, you have to ask pregnancy and recent delivery because folic acid is required in a high quantity in a pregnancy and lactation. Then residence in tropics, she resides in tropics because tropical sprue can develop diarrhea and can produce B12 deficiency. So, residence in tropics is important. Then especially in megaloblastic anemia, drug history is important because some of the drugs like metformin and proton pump inhibitors can produce B12 deficiency, whereas there are antifolate drugs which will produce, which are antagonists to the folate like methotrexate, pyrimethamine, trimethoprim. Sometimes even antitubercular drug, nitrofurantoin, tetracyclines can act as an antifolate antagonist. Not only that, sulfadiazine, cholestyramine, trimethoprim will inhibit the absorption of folic acid. Okay, that is why drug history is important, especially in the megaloblastic anemia. Then any previous abdominal operation or disease like ileocecal tuberculosis or a Crohn's disease, or whether any operation has been done with ileal resection, you have to ask in the megaloblastic anemia because B12 is absorbed in the ileum. Okay. Now, pertaining to the B12 deficiency, okay, I want to ask some other points in the history. The gastric cause of B12 deficiencies are absent intrinsic factor. For example, if the patient has undergone a total or a partial gastrectomy, intrinsic factor will be totally deficient. So they develop megaloblastic anemia. Or if endoscopy shows atrophic gastritis, previous evidence of atrophic gastritis, because parietal cells will undergo atrophy, parietal cells will secrete the B12. So they can develop B12 deficiency. And whether there is any history of Zollinger-Ellison syndrome by endoscopy and blood test investigation. Zollinger-Ellison syndrome, because of the decreased pH, the trypsin won't get activated. And trypsin is needed for the cleavage of the B12 from the R binder. Then only B12 can club with the intrinsic factor, it can be absorbed in the ileum. B12 cannot be cleaved from the R binder if trypsin is not there, and trypsin will be inactivated by Zollinger-Ellison syndrome, decreased pH. So, whether patient is suffering from Zollinger-Ellison syndrome, you have to ask in the history for a B12 deficiency, or any bariatric surgeries to reduce weight, whether they have undergone, you have to ask. And proton pump inhibitor is one drug which can produce B12 deficiency apart from metformin. So, then whether patient is having pernicious anemia, that you have to, it's autoimmune disease which is confirmed by autoantibodies. So, that history you have to ask. Okay. And then food absorption, the cobalamin absorption because of the intestinal causes like stagnant loop syndrome. Then whether patient has undergone any ileal surgeries, 1.2 meters of ileum if it is resected, then they can develop B12 deficiency. Whether she has undergone ileal resection, you have to ask. Then tropical sprue. Then whether patient is having a fish tapeworm, okay, whether diagnosed to have fish tapeworm, so that you have to ask because fish tapeworm will produce B12 deficiency. Then gluten enteropathy because it can reduce the B12 absorption from the ileum, that history you have to ask. Then chronic pancreatitis, as I told before, in chronic pancreatitis there will be decreased trypsin and calcium which will reduce the B12 absorption. So, chronic pancreatitis, we asked in our abdominal pain, we asked, and diarrhea, which is a triad of chronic pancreatitis, abdominal pain, diarrhea and diabetes mellitus. Then history of whether she is suffering history of exposure, HIV history is important because 10 to 35% of the HIV patients will have B12 deficiency. So, history of exposure you have to ask because they can develop B12 deficiency, and any radiotherapy and graft versus host disease. Okay, if they have undergone any bone marrow transplantation, they can develop B12 deficiency. So, any history of radiotherapy, radiation therapy, graft versus host disease, and the other drug is metformin as well, apart from proton pump inhibitor, which can produce B12 deficiency. That you have to ask. And whether she is working, she is a student. Whether they are working in a OT setup, a nurse working in a OT setup because of nitrous oxide inhalation can develop B12 deficiency. So, you have to ask the occupation, whether they are a surgeon or OT technician who is a nitric oxide as an anesthesia, they can develop B12 deficiency. So, these history you have to ask in a B12 deficiency. Coming to the folic acid. Folic acid in the diet history, goat's milk. Those who consume only goat's milk, okay, especially in Andaman and Nicobar, they consume goat milk. So, goat milk doesn't contain the folic acid. So, in the diet history, goat milk you have to ask, okay. And malabsorption as in B12 deficiency like tropical sprue, gluten enteropathy, that can also interfere with the folic acid absorption. Then excess utilization and loss from the body. For example, in a pregnancy, you need excess utilization, okay. And prematurity, premature baby requires high folic acid, 10 times more than the normal adult folic acid requirement in a premature baby, okay. Then hematological conditions where there is an increased turnover of the RBCs like hemolytic anemias especially, you require more folic acid. They can develop folic acid deficiency, okay. Because in these hematological disorders, the folic acid which is utilized for the coenzyme function, after that it is not reutilized properly. That is why they are more prone to develop folic acid deficiency, okay. So, you have to ask that point. Then some inflammatory conditions can produce folic acid because of the increased requirement, chronic inflammatory conditions because of the increased requirement of the folic acid. And if the patient is suffering from homocystinemia and homocystinuria, what happens is homocysteine is converted to methionine by utilizing the folic acid, and they can develop folic acid deficiency. Those who have a congenital homocystinemia and homocystinuria, because homocysteine is converted to methionine by utilizing the folic acid, they can develop folic acid deficiency. Then, increased utilization and loss can occur in congestive heart failure and liver disease patients. So, because there will be increased urinary excretion from the damaged liver cells which contains the folic acid, okay. So, whether patient is suffering from any liver disease or whether patient is having any congestive heart failure symptoms, you have to ask, because increased folic acid utilization and loss can occur, okay. And lastly, as I told, folic acid deficiency, there are some drugs which will act as antifolic drugs, the pyrimethamine, triamterene, methotrexate, nitrofurantoin, tetracycline, antitubercular drugs, okay. And there can be a decreased absorption by some other drugs like sulfadiazine, triamterene and cholestyramine, okay. Cholestyramine, triamterene, sulfadiazine will decrease the absorption of folic acid from the GI tract. So, drug history is very important in a megaloblastic anemia. So, these are the points which you have to ask in the detail in the history about the iron deficiency anemia and megaloblastic anemia. For example, if the patient is having normocytic normochromic anemia, what are the things you ask in the history pertaining to the anemia? So, blood loss, acute blood loss, if the patient met with an accident, lose 1 liter of blood, they are more prone to develop normocytic normochromic anemia, acute blood loss. Whether any history of trauma producing acute blood loss, you have to ask. Then bleeding tendencies, suppose if they have a leukemias with a low platelets, they can bleed, okay. So, you have to ask them whether they have increased bleeding tendencies, the ecchymosis, petechiae are there, you have to ask. Then nocturnal polyuria, as I told CKD, they can have normocytic normochromic anemia, nocturnal polyuria, facial puffiness, you have to ask in the history, and bony pain. Acute leukemias can have a marrow expansion, so patient can have a bony pain. So, that point you have to ask in the history. Then symptoms suggestive of myxedema, can have normocytic normochromic anemia, facial puffiness, cold intolerance. Then hypopituitarism, okay. So, again TSH will be less, they can produce a normocytic normochromic anemia. Then suppose if anemia is associated with thrombocytopenia and neutropenia, in a pancytopenia case, what are the things you will ask, okay. So, here you will ask the diet history and occupation history, because occupation, some of the industrial toxins can produce aplastic anemia, B12 deficiency can produce pancytopenia. So, diet history is important. So, exposure to chemicals, drugs and radiation is important in a pancytopenia because they can develop aplastic anemia. Then history of any bony pain, as I told, malignancies, the blood malignancies can develop the aplastic anemia and pancytopenia. Then history of fever, night sweats, weight loss and pruritus. These are the symptoms suggestive of lymphoma. Lymphoma and chronic malarial hyperreactive splenic syndrome, okay, and then the alcoholic liver cirrhosis with portal hypertension can have a massive splenomegaly and hypersplenism, which can produce pancytopenia. So, diseases which can produce hypersplenism like cirrhosis, lymphomas and a chronic malaria, you have to ask in the history if the patient has pancytopenia in the history. Coming to the hemolytic anemia, what are the points you will ask in the history? Like our patient, the symptoms she told she started since 3 months or 4 months of age. So, some of the inherited hemolytic anemia symptoms begins at a very young age. So, age of onset, the sex, for example, GCPD deficiency is X-linked recessive, males will be affected. So, sex is important, age of onset of the symptoms is important and race. GCPD deficiency is common in the Middle East countries. Okay, in India it is not common. So, race is important in hemolytic anemia. Then occupation, because some of the toxins can produce hemolysis, so occupation is also important. Then jaundice, our patient is history of jaundice. So, history of jaundice is important, hemolytic anemia, they have jaundice. Then color of the urine and feces. Though they have jaundice, the urine color and the feces color won't get altered because here it's the interior bilirubin which will be elevated, which won't excreted in the urine. So, urine won't be yellow color. Then history of abdominal pain, as I told before, because they are more prone to develop cholelithiasis, so it was history of abdominal pain. Family history, so some are autosomal recessive, some are X-linked recessive, some are autosomal dominant. Okay, so you have to ask family history in a case of hemolytic anemia. And previous history of repeated blood transfusion. Okay, our patient is giving that history since 6 months, every 20 days she is getting a blood transfusion. So, previous history of repeated blood transfusion history is important. Then symptom suggestive of disorders causing autoimmune hemolytic anemia. So, this is important. Some of the disorders will produce autoimmune hemolytic anemia. For example, a cytomegalovirus infection, Epstein-Barr virus infection, HIV infection, the viral vaccines, then chronic lymphatic leukemia, hematopoietic stem cell transplantations, okay, and inflammatory bowel disease, lymphoma, the drugs, methyl dopa, penicillin, piperacillin can produce it, okay, and ceftriaxone can produce the autoimmune hemolytic anemia. So, the diseases which produce autoimmune hemolytic anemia, you have to ask in a case of hemolytic anemia whether they are taking those drugs, whether they are exposed to those drugs, or any viral infection is there, or they are suffering from HIV or CLL or lymphoma or SLE. You have to ask those symptoms in autoimmune hemolytic anemia. Then whether hemoglobinuria occurs in relation to sleep. So, for example, paroxysmal nocturnal hemoglobinuria, PNH, usually the hemoglobinuria occurs in night, even daytime also it occurs, but night time they give the history that there is a hemoglobinuria. Or hemoglobinuria occurs due to cold, paroxysmal cold hemoglobinuria. Or hemoglobinuria occurs due to exercise, for example, sickle cell anemia, during exercise they will undergo dehydration and hemolysis will occur in that sickle cell anemia. So, with exercise and with drugs, for example, GCPD deficiency, the drugs will produce the hemolysis. So, which are the drugs we will ask in the history in GCPD deficiency? Antimalarials like chloroquine, primaquine, quinine, dapsone, proguanil. Antibiotics like ciprofloxacin, norfloxacin, nalidixic acid. Antibiotics like sulfamethoxazole, sulfadiazine, the sulfonamide antibiotics, cotrimoxazole, para-aminosalicylic acid, paracetamol, naphthalene. All this will precipitate the bleeding, the hemolysis in GCPD deficiency. So, drugs history you have to ask whether that can precipitate hemolysis. So, these points you will ask in the history, and drugs, chemicals you have to ask, and Raynaud's phenomena in hemolytic anemia. As I told, sickle cell anemia and some of the autoimmune hemolytic anemia will have a Raynaud's phenomena. So, symptoms suggestive of Raynaud's phenomena you have to ask in the hemolytic anemia. So, these are the points in the history students detail you have to ask in the case of anemia pertaining to the etiology. Okay. So, we asked all those points in her, okay, and now let us go on to the further history, the past history in her. She has been diagnosed to have thalassemia at the age of 3 months of age student in CMC Vellore, at 3 months of age. There is no history of tuberculosis, epilepsy, diabetes or hypothyroidism. No history of any radiation exposure. So, there is no history of any radiation exposure. This is the past history. Coming to the family history, there is a consanguineous marriage between the father and the mother. In the father side, till now nobody is affected from the history wise. From the mother side also nobody is affected till now. The parents had one abortion after she was born, and then one more male baby is there not affected. So she is the only one who is affected, and mother and father is a consanguineous marriage. Second degree consanguineous marriage. And she told the father and mother were investigated for the genetic analysis and both are carriers. Because thalassemia is an autosomal recessive condition, it is not manifested in mother and father. And because she has got the gene both from the mother and father, the affected gene, she is a homozygous. Though autosomal recessive, it is manifested in her. So this is a pedigree chart, students. Then drug and medical history, as I told in the history, what are the drugs you will ask in a anemia, in a megaloblastic anemia, folic acid deficiency, DSPD deficiency, what are the drugs you should ask in the history I discussed. She is taking tefaroxirox 400 mg BD. The dose of tefaroxirox is 20 to 30 milligram per kg body weight you have to give, okay, and she is taking 400 milligrams BD, okay. The 2 tablets in the morning, 1 in the night since 10 years. Okay, as a chelating therapy, they are giving her. And she tells every once in 20 days, she is getting 2 bottles of blood transfusion since 3 months of age, students. Okay, right. Because here the disease developed in the childhood at the 3 months of age, okay, and manifested like that, and she requires blood transfusion. It is beta thalassemia major. It is the thalassemia major. Okay. And they have investigated and it has come as a beta thalassemia major, which I will discuss at the end of the case discussion detail about the thalassemia. Coming to the personal history, she takes mixed diet. Diet is important, as I told, because B12 deficiency will occur in a pure vegetarian food takers. Okay, non-vegetarian food only contains the B12 apart from curd or some dairy milk where little amount of B12 is present. So diet is important, and goat's milk, as I told, if they consume only goat's milk, they develop folic acid deficiency. No history of addictive habits, and still she is not married. The menstrual history, very important in a case of anemia, as I told before, especially in iron deficiency anemia. Age of menarche in her is 12 years. No history of excessive menstruation. Normal flow, regular cycles, 3 days for 28 days. Okay, so this is the history, students. So because here she gives history since 3 months of age, she is getting the blood repeated, and she has been investigated, and she is getting iron chelating therapy. Okay, so she is having a hemolytic anemia. Okay, hemolytic anemia. Probably they investigated later and they have found what type of hemolytic anemia she is having. Okay, right. So in a case of anemia, students, top to bottom, what all you will examine pertaining to the each anemias. Iron deficiency, what you will see. Megaloblastic, what you will see. Normocytic anemia, what you will see. Hemolytic anemia, what you will see. We will see from top to bottom. Patient is conscious, oriented, moderately built and nourished. Blood pressure is 100/70. Right arm supine position. Pulse rate is 76 beats per minute. Regular, normal in character. She is afebrile. Okay. Now let us come to the examination top to bottom in her. So students, let us examine top to bottom general physical examination in a case of anemia. What you will look. Normally the hair will be lusterless. Okay, but here the hair is not lusterless. Okay. Then you can see here there is a frontal bossing, okay, the frontal bossing here in the forehead, okay, and even there is a maxillary prominence. You can make out the maxillary prominence, both the sides, here and here there is a maxillary prominence, okay. Now let us look for the anemia. Male nodi, she is pale, male nodi, she is pale, okay. Then you have to look for a jaundice. There is a light tinge, okay, there is a light tinge, especially in hemolytic anemia, you will get only a mild jaundice. It will bilirubin never be more than 5 milligrams per deciliter. What are the other things you look in the eye in a case of anemia? Any conjunctival hemorrhage is there, you have to look, because a bleeding manifestation in acute leukemias can manifest as a conjunctival hemorrhage. Any KF ring in the slit lamp examination is very important, because Wilson disease can have a hemolytic anemia. So KF ring you have to look, okay. Now, next coming to the mouth. What are the things you look in the mouth? Nalge torsi. There is no glass eye test. The papillas are seen. Hal torsi. Yeah. So, gum bleeding and gum hypertrophy you have to see some. So, gum hypertrophy and a gum bleeding you get in acute leukemia. So, you have to look for gum hypertrophy, gum bleeding. And the tongue color is important. In a B12 deficiency, you get a beefy red colored tongue. And glossitis is a feature of beetle deficiency as well as iron deficiency anemia, and a bald tongue is there you have to look. She is getting repeated transfusion to maintain the hemoglobin around 8 to 10. That is why the tongue papillas are seen. Okay, there is no bald tongue, there is no glossitis. So this is the examination. In the face, these are the things which you look. So I repeat, she has a maxillary prominence, frontal prominence is there. You have to look for the pallor in the palpebral conjunctiva, jaundice, KF ring, then beefy red color tongue, then gum hypertrophy you have to look. And also the gum, if it is a bluish black discoloration, indicates a lead toxicity which can produce a anemia, a lead anemia. So that you have to look in the gum. So let us come to the neck examination. In the neck, you have to look for lymphadenopathy, because lymphadenopathy is a feature of CLL, lymphomas, acute leukemias, which can produce anemia. So students, let me examine the lymph nodes on her. As I told, lymph node examination should be always on the back side. Let me examine the lymph nodes. Submandibular, submental, cervical group of lymph nodes, and supraclavicular. So it is not enlarged. And one more thing you want to look in the neck is venous hum in a case of anemia. Okay, venous hum at the base of the neck you will auscultate with the bell of the stethoscope, and you make the face turn toward the opposite side. You will hear a venous hum. It is a continuous. Then if you make the face again back to the front straight, then that venous hum will disappear. Let me examine for a venous hum on her. At the base of the neck, turn the face toward the opposite side. You will hear a venous hum if it is there. Then again turn straight. This is how you look for a venous hum in a case of anemia, students. Okay. Now let us come to the examination of the hand. What are the things you see in the hand? So in the hand, students, she has clubbing. You can make out here, there is a clubbing. Okay, probably this is a congenital clubbing, not related to the anemia, because it is not described. You will get clubbing in an anemia. She has a clubbing. Okay, then you have to look for the nail changes in anemia. Okay, what are the nail changes you get in iron deficiency anemia? The nail will become brittle, then longitudinal ridges you can see, then platinanchia, then colonanchia. Platinanchia is a flat, colonanchia is a spoon shaped. These changes, the brittleness of the nail, the longitudinal ridges, platinanchia and colonanchia, these nail changes indicates chronic iron deficiency anemia. Chronic iron deficiency anemia. Then other thing what you want to see in the hand is palmar creases. Here palmar creases are not obliterated, so probably her hemoglobin is not less than 50% of the normal. So palmar creases are not obliterated. So you have to look for any obliteration of the palmar crease. If palmar crease is obliterated, the hemoglobin is 50% of the normal. So these are the things which you look in the hands. Next, in the skin, what are the things you look in the skin? So whether any petechiae or ecchymosis are present, you will see, because petechiae and ecchymosis indicates acute leukemias. Okay, because of thrombocytopenia, you have to look for that. Okay, then you have to look for in the chest. You have to look for any sternal tenderness. The sternal tenderness is a feature of acute leukemias. So in acute leukemias, middle 1/3 and lower 1/3 of the sternum, you have to put your thumb and see any sternal tenderness is there. You have to see. Especially is a feature of acute leukemias. You have to look for that. Then coming to the legs, whether there are any leg ulcers are there, you will see, because leg ulcers is a feature of hemolytic anemia, especially sickle cell anemia and thalassemia. So let me examine the leg. Any ulcers are there? So there are no leg ulcers. Let me look for a pedal edema. She has pedal edema, but no leg ulcers. Leg ulcers are not present. The other pertaining to the examination, pertaining to each system, we will go by system wise, okay, what to examine, okay, and then we will discuss at the end of examination in each anemia, what are the things you will examine. And one more thing, in iron deficiency anemia, you have to look for any telangiectasias in the mouth, okay, because Osler-Weber-Rendu syndrome, they can bleed and they can produce iron deficiency anemia. So, let us go to the examination in the case of anemia system wise now. So, students, let me examine the cardiovascular system in a case of anemia. What will happen to the pulse rate in anemia student? It is a high output state. So, they will have tachycardia. A high volume pulse will be there. Okay, pulse pressure may be increased in a case of anemia. And because of tachycardia on auscultation, I may get a loud S1. Because it is a high output state, because of more blood flow across the pulmonary artery, you will get a hemic murmur at the base of the heart in the pulmonary area. A hemic murmur, tachycardia, loud S1. Another important thing in a case of anemia, what you have to examine is, especially in hemolytic anemia, is any artificial sound is there in the heart, you have to look. Because a prosthetic mechanical wall, if it is there, the RBCs has to undergo that prosthetic mechanical wall, they will undergo hemolysis. So, prosthetic wall sound is there, you have to look. Let me examine her cardiovascular system. Student, she has a hemic murmur. In a pulmonary area, there is a hemic murmur, there is tachycardia, even S1 is loud on her. There is no any artificial sound, okay, not heard on her. So, these are things which you look in cardiovascular system examination. Now, let us come to the examination of the abdomen, which is very important. Before examining, let me tell what are the things you will look in an abdominal examination. The organomegaly and very fluid accumulation is there, which features suggestive of ascites with a liver cirrhosis. These things you have to see, or any scars of a previous operation is there, you have to see, okay, previous abdominal surgery operations. Hepatomegaly, splenomegaly, and any ascites is there, which suggestive of cirrhosis you have to see. Let me examine the hepatomegaly, splenomegaly, okay. The other way to examine the liver, there is no hepatomegaly. Let me examine the spleen. No splenomegaly. Is that recording? Yeah. The other method, right lateral method. So, there is no organomegaly students in her, and there is no fluid accumulation also. Abdomen is not distended. Okay. There is no hepatosplenomegaly. This examination is important because organomegaly, hepatosplenomegaly is a feature of B12 deficiency, leukemias, lymphomas. So, you have to look for organomegaly. Next, come to the central nervous system examination. What are the things you look in CNS examination in a case of anemia, especially in a megaloblastic anemia? So, signs of peripheral neuropathy. You have to look in the hands and legs whether any loss of sensation is there or loss of ankle reflex is there, you have to look. Let me examine the touch sensation, pain sensation, and then the ankle reflex and vibration sensation on her. Fine touch is normal, she can appreciate in the hand and the foot. Let me examine the pain. Pain is also normal. Let me examine the vibration. ಇದು ಇಡ್ತೇನೆ ಇಟ್ಟಾಗ ಮುಟ್ಟೋದಲ್ಲ, ಹಿಂಗೆ ಹಿಂಗೆ ವೈಬ್ರೇಷನ್ ಆಗೋದು ಗೊತ್ತಾದರೆ ಅದನ್ನು ಹೇಳಬೇಕು. ಹಿಂಗೆ 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 ಆಗುತ್ತಲ್ಲ ವೈಬ್ರೇಷನ್. ಕಣ್ಮುಚ್ಚಿ. Vibration is also normal. Let me examine the ankle reflex. Ankle reflex. It's present. Let me examine this side. it's present this side also. Anyhow, symptom wise, she didn't give any complaint. There is a loss of balance, tingling and numbness sensation. Even on examination, there are no signs of peripheral neuropathy. Okay, this examination is important, especially in a case of megaloblastic anemia. Respiratory system, probably a symptom wise, if there is any hemoptysis there, so that is important because it can produce a loss of blood and they can develop a anemia. Okay, so these are the things which you look in the examination, students. So just I want to summarize what all you want to see in a case of anemia relevant to the pertaining type of anemia. In iron deficiency anemia, as I told you, look for telangiectasias of the face and mouth because it can bleed and produce iron deficiency anemia. In a megaloblastic anemia, you have to look for a general nutrition. Any jaundice is there, you have to look because it can produce a mild icterus. Then tongue, you will look for a glossitis. Then abdomen, any surgeries because ileal resection can produce beetle absorption and organomegaly. Beetle deficiency can be associated with hepatosplenomegaly, so you have to look for organomegaly. Then especially neuropathy, as I examined here, in this case you have to look for neuropathic signs in a beetle deficiency. And knuckle pigmentation in the hands, you have to look in a beetle deficiency, very important sign. Okay, you have to look for knuckle pigmentation, which our patient is not having, the knuckle pigmentation. In a normocytic anemia, what are the things you will look, especially in the skin petechiae and ecchymosis, because acute leukemias can bleed, you have to look for that. Then conjunctiva, you look for any conjunctival hemorrhage is there, you have to look for that. And para-abdomen in normocytic anemia, you have to look for hepatosplenomegaly because acute leukemias, lymphomas can have organomegaly. Then ascites, any mass is there, you have to look for that. Then normocytic anemia, signs of CKD like fundus examination for retinopathy, and you have to look for any increased blood pressure in a CKD, you have to look for that. Then normocytic anemia, you have to look for bony tenderness, as I looked in a sternal tenderness because acute leukemias will have a bony tenderness. Then in normocytic anemia, you have to look for signs of myxedema which can produce normocytic anemia, so facial puffiness, delayed ankle reflex you have to see. Then in normocytic anemia, other two important thing is any chronic inflammatory disease markers are there, you have to see. For example, tuberculosis can produce a normocytic anemia because of chronic inflammation. So markers of tuberculosis like lupus vulgaris, scrofuloderma, flictonellar conjunctivitis, erythema nodosum, these things you have to look in a fungal infection, which she is giving the history but may not be related to in her case. So any stigma of tuberculosis or any joint deformities is there like rheumatoid arthritis, which can produce normocytic normochromic anemia, you have to look in the examination top to bottom, joint deformities. In the case of pancytopenia, again because of the leukemias and lymphomas, you have to look for any lymph nodes, splenomegaly, bony tenderness, gum hypertrophy is a feature of acute leukemias, and hepatomegaly you have to look. And the diseases which produces a hypersplenism like a portal hypertension, lymphomas, chronic malaria, those signs are there, you have to look in a case of pancytopenia top to bottom. Then in a pancytopenia, because of the metastasis to the bone by the malignancies like a breast, a lung, a prostate in a male, you have to look whether patient is having any signs of those malignancies is there, you have to look in a case of anemia, especially in a pancytopenia. In the hemolytic anemia, you have to look for a pallor, okay. Then cyanosis, because some of the abnormal hemoglobins like methemoglobinemia can have a cyanosis, so you have to look for cyanosis. Jaundice, as I told, mild jaundice will be there in a hemolytic anemia. Organomegaly, splenomegaly is a feature of all the hemolytic anemias, okay. And then the faces, like our patient who is having a maxillary prominence because of the extramedullary erythropoiesis. So typical faces you have to look in a case of hemolytic anemia. Then signs of disorders causing autoimmune hemolytic anemia, as I told in the history wise, the CLL, SLE, HIV, drugs, the penicillin, ceftriaxone, methicillin, methyl dopa, all these can produce autoimmune hemolytic anemia, and lymphomas. So those signs are relevant to those diseases which produce autoimmune hemolytic anemia, you have to look in the case. The one more drug which can produce autoimmune hemolytic anemia is checkpoint inhibitors. So these are the things which you look in a case top to bottom in the case, okay, right. So our patient is having maxillary prominence, that is the one finding which she is having, okay. That is the one finding which she is having, and she tells she has been diagnosed with hemolytic anemia in a CMC Vellore at the 3 months of age. So in a CMC Vellore, they diagnose her to be having a beta thalassemia major. Since 3 months, every 21 days, she is receiving the blood. 2 units for every 20 days, she is receiving the blood. Let me discuss the approach to anemia later, okay. and her latest investigation report is her hemoglobin is 7.9, total count is 3200, platelet is 1.97, SGOT, SGPT, SGOT is 50, SGPT is 30, that is normal. The bilirubin, direct, indirect is normal. Iron studies, they are all in normal level. Her iron studies are normal levels. Okay, right. So, this is a nice case of beta thalassemia major presented since childhood, where she is receiving the iron chelation therapy as well as the blood transfusion once in 20 days. Okay. Not only thalassemia, though this is a rare, but the other anemias like iron deficiency anemia and beetle deficiency anemia, which is a very common malnutrition anemia in India, which can be kept for the exam. Pertaining to all the anemias, what are the points you have to ask in the history and what are the things you have to examine from top to bottom? So, I have discussed it. So, if any anemia they keep in the exam, whether B12 or iron deficiency or hemolytic anemia, you should be able to take the history, you should be able to examine the case, okay, top to bottom. So, after discussing the history and examination, I want to tell points about how you approach a case of anemia and what are the investigations you do and how do you treat. So, the investigation students, what you do is CBC, in that you will do hemoglobin, RBC count you will do, reticulocyte count. The reticulocyte count is normally 1 to 2%. Suppose if the patient has anemia, then you have to correct two corrections for the reticulocyte count. One correction for the anemia and another is a shift correction. For example, one patient has a reticulocyte count around 8% and her hemoglobin is 7. Then you have to correct for the anemia. That is, you have to, patient is having half of the normal hemoglobin. So, you have to divide the reticulocyte count 8% by 2, that is the first correction for the anemia. The next correction is shift correction, because these premature reticulocytes which are come to the outside to the blood, they are having a longer life period compared to the normal reticulocytes which are released to the blood. These premature reticulocytes which are released to the peripheral blood, they are known as polychromasia. If polychromasia is there in the peripheral blood, you have to do a shift correction. Again, you have to divide that which you have corrected for the anemia again by 2. So, 4 divided by 2, then that becomes a 2. So, 2 is the reticulocyte count production index, RPI. So, you do 2 corrections for reticulocyte count. Some labs give the reticulocyte count in absolute numbers. If they give in absolute numbers, then no need of any correction. Only if they give in percentage, you have to correct the reticulocyte count. So, hemoglobin, hematocrit, reticulocyte count. Then what you will do? Other tests in a case of anemia. Then red cell morphology and RBC indices. Red cell morphology, you will see the size. For example, there may be very small size microcytosis or it may be a large macrocytosis. Then hemoglobin content, there can be a microcytic hypochromic, hemoglobin content is less. Then anisocytosis, poikilocytosis. Anisocytosis is alteration in the size of the RBCs. One may be small, one may be big, like that, there will be alteration in size, anisocytosis. Next is poikilocytosis, alteration in the shape of the RBCs, poikilocytosis. Then polychromasia. Polychromasia means, as I told, immaturely released reticulocyte count to the peripheral blood. Whether polychromasia is there or not, you will see. Then RBC indices. Which are the RBC indices you will see? Mean corpuscular volume. Mean corpuscular volume is calculated by hematocrit divided by RBC count. Normal is around 90 plus or minus 8 femtoliter, mean corpuscular volume. The mean corpuscular hemoglobin, MCH. MCH is calculated by hemoglobin divided by RBC count. MCH is 30 plus or minus 3 picograms. Next is MCHC. MCHC is nothing but MCV divided by MCH. It is a ratio, so it is expressed only in a number, not any picogram or anything like that. The normal value is 30 plus or minus 2, MCHC. These are the RBC indices which you will do. Then you will do differential count, The neutrophils. The neutrophils can be hypersegmented neutrophils, especially you get in a B12 deficiencies. Then platelet count. Then you will do bone marrow examination. Bone marrow examination, you can do aspiration, which will indicate the marrow cellularity and marrow morphology and myeloid erythroid ratio. Bone marrow biopsy you can do, which indicates the morphology and cellularity. So, along with this reticulocyte count, myeloid erythroid ratio, how do you interpret IEL? In a hyperproliferative anemias, the reticulocyte count will be less than 2.5. The myeloid erythroid ratio will be either 2:1 or 3:1. The myeloid part will be more, erythroid will be less in hyperproliferative anemia in the bone marrow. And reticulocyte count will be less than 2 in hyperproliferative anemia. Whereas in hemolytic anemia, reticulocyte count will be more than 2 and myeloid erythroid ratio will become 1:1 because erythroid is synthesizing more in hemolysis. Bone marrow is normal, so it synthesizes more RBCs. Myeloid erythroid ratio will become 1:1. Then other thing which you do in investigation, basic investigation in anemia is iron studies. The normal serum iron is 50 to 150 microgram per deciliter. Total iron binding capacity is 300 to 360 microgram per deciliter. Percentage saturation of the iron 25 to 50%, normal percentage saturation of the iron. Serum ferritin level, males 100 microgram per deciliter, females 30 microgram per deciliter. If the iron level is around 10 to 50, if the serum ferritin level is 10 to 15 microgram per deciliter, that indicates the bone marrow stores are 0, the iron stores are 0. Then RBC protoporphyrin level you will estimate. RBC protoporphyrin level normally is around 30 microgram per deciliter. In iron deficiency anemia, RBC protoporphyrin level will become 100 microgram per deciliter. Then transferrin receptor protein will be increased in iron deficiency anemia. Then in an approach, in any case of anemia, first you will do reticulocyte count index. So based on reticulocyte count index, whether it is less than 2.5 or more than 2.5, it is divided into two things. More than 2.5 reticulocyte count index in the case of anemia is a feature of hemolytic anemia because marrow is synthesizing more and more blood. Less than 2.5 reticulocyte count can get in two conditions. One is hyperproliferative anemia or a maturation disorder. So in a hyperproliferative anemia, reticulocyte count index will be less than 2.5. Which are the conditions? And in hyperproliferative anemia, the RBC shape size will be normal, not altered, like in a maturation disorder where either size is less or size is big. So, reticulocyte count index less than 2.5 with the normal shape and size of the RBCs. This is hyperproliferative. The causes are mild iron deficiency, you get hyperproliferative anemia, whereas a severe you get a maturation. I will tell later that. So, mild iron deficiency is hyperproliferative anemia, myxedema, CKD, inflammation, anemia of inflammation, chronic inflammation like rheumatoid arthritis, tuberculosis, or a marrow disorder like aplastic anemia or myelofibrosis. These are the hyperproliferative anemia where RBC shape and size is normal, reticulocyte count index is less than 2.5. Then comes the maturation. Here also reticulocyte count index is less than 2.5. The maturation will be a problem which will alter the shape and size of the RBCs. It can be cytoplasmic maturation problem or a nuclear maturation problem. Cytoplasmic maturation problem is three conditions: thalassemia, severe iron deficiency anemia, sideroblastic anemia. Whereas a nuclear deficiency problem, nuclear maturation problem, you get in folic acid deficiency, B12 deficiency, and sometimes in myelodysplastic syndromes. So, this is how you approach in general a case of anemia from your basic investigation. Now, let us come into the hemolytic anemias. Before going to hemolytic anemias, in iron deficiency anemia, I just want to, apart from all this investigation, how do you treat, and B12 deficiency, what are the investigations you will do and how do you treat, and then let us go to the hemolytic anemias. So, in iron deficiency anemia, you will, after doing RBC indices, iron studies you will do, okay, and then you will confirm it is a microcytic hypochromic with iron deficiency. You will treat with oral iron preparations or parenteral iron injections. Oral parenteral preparations are ferrous sulfate, ferrous fumarate, ferrous gluconate, polysaccharide, iron. Parenteral iron injections are ferromoxetol, iron sucrose, iron dextran, sodium ferrigluconate, ferricarboxymaltose. How do you calculate the total iron dose required, total iron dose required in a patient? It is calculated by formula 2.3 into hemoglobin deficit, okay, weight in kg into weight in kg plus 500 or 1000 milligrams of stores. So, 2.3 into hemoglobin deficit into weight in kg plus 500 or 1000 milligrams in a male and female, okay, the stores. That is how you calculate the total parental iron dose required. You can do a oral iron tolerance test. You can give 2 tablets of the iron, okay, and then after 2 hours, if the serum iron is less than 100 microgram per deciliter, then iron is not absorbed properly. You can use this test for iron absorption and an oral iron tolerance test. Coming to the B12 deficiency students, B12 is measured in the blood by ELISA technique. The normal blood level is 160 nanogram per deciliter to 200 nanogram per deciliter to 1000 nanogram per deciliter. That is the range of the B12. If B12 level is less than 100 nanogram per deciliter, then B12 deficiency is confirmed. And in a pernicious anemia, intrinsic factor antibodies will be present, antiparietal antibody, anti-intrinsic factor antibody will be present, and there will be pepsinogen will be less, pepsinogen will be less, and intrinsic factor level will be less in a pernicious anemia. How do you treat B12 deficiency? If it is due to a tropical sprue, if it is due to a fish tapeworm, or if it is due to a intestinal stagnant syndrome, there is a permanent cure. Earlier they used to do Schilling test for B12 deficiency estimation, but nowadays it is outdated. Apart from ELISA, there is one more method known as CBLA method, competitive based luminescent assay, to estimate the B12 level, but it will give false positives in 50% of the cases. That is why it is not indicated. ELISA is indicated. B12 deficiency, you will get a megaloblastic picture in the blood, okay, and also hypersegmented neutrophils in the peripheral blood smear. You treat with 1000 microgram hydroxycobalamin injections every day for 1 week, every injection in a week for 1 month, then every monthly injection for lifelong preferably. This is how you treat a B12 deficiency. Folic acid students, it is again done by the ELISA method. The normal range is 2 to 15 microgram per deciliter folic acid, and you can do you can diagnose the folic acid deficiency by asking a proper diet history, transglutaminase antibody, and the intestinal biopsy you can take why they are having a folic acid deficiency, whether due to a malabsorption or due to a tropical sprue or due to a celiac sprue. You can diagnose by doing that. Folic acid you give 5 to 15 milligram per kg per day, 5 to 15 mg per day as a treatment in a folic acid deficiency for 3 to 6 months. And normally sometimes you have to supplement the folic acid whenever there is an increased requirement. For example, in a pregnancy is an increased requirement for folic acid. You have to give 400 microgram every day in a pregnant lady. If the pregnant lady has a previous history of a neural tube defects, then you have to give throughout the pregnancy, you have to give around 1 mg, 5 mg per day if the previous history of neural tube defect. If there is a premature baby which weighs less than 1500 milligram, then the baby you have to supplement 1 mg per day folic acid, because the requirement in a premature baby is 10 times more than the normal person of a folic acid. So, you have to replace that. So, this is a folic acid and B12 deficiencies. So, coming to the little about the hemolytic anemias, there are some typical features for all the hemolytic anemia which shares some common features. The clinical feature is they will have anemia. They will have jaundice, a mild jaundice, lemon yellow color jaundice will be there. Splenomegaly, all the hemolytic anemias will have splenomegaly. Typical faces like in her, the maxillary prominence they can have. And some hemolytic anemia may have the leg ulcers. Investigation wise, they will have anemia, hemoglobin will be less. MCV or MCH may be increased in hemolytic anemia. MCV or MCH may be increased. Decreased haptoglobulin, increase LDH more than 10 times the normal, increase LDH, then increase bilirubin level. Then they can have cholelithiasis. These are some of the common features for all the hemolytic anemias. The classification very simple. First intracorpuscular, then extracorpuscular you make. Intracorpuscular could be in the membrane like hereditary spherocytosis or hereditary erythrocytosis. Then coming to the hemoglobinopathies like sickle cell thalassemias. Then intracorpuscular enzymes like GCSPD deficiency, enzyme disorders. So, enzyme disorders, hemoglobin, membrane disorder, all intracorpuscular. All intracorpuscular are inherited except one, that is PNH. PNH is an acquired intracorpuscular hemolytic disorder where the problem is with the CD55, CD59 absence in the membrane. Then coming to the extracorpuscular infections like malaria, drugs, autoimmune hemolytic anemia, March hemoglobinuria, HUS and TTPs. Extracorpuscular. All extracorpuscular are acquired students except only one, that is known as atypical HUS, which is a genetic. All extracorpuscular are acquired except one, that is atypical HUS, which is genetic. This is in general the classification of hemolytic anemia. Now coming to the, we will go one by one. The hereditary spherocytosis you can diagnose by doing osmotic fragility test. Depending on the severity of anemia, you can do splenectomy and you can give blood transfusion to maintain hemoglobin around 10. Coming to the hemoglobinopathy, thalassemia I will tell briefly after the end of this discussion. In sickle cell anemia, how do you diagnose? You diagnose by doing hemoglobin electrophoresis, sickling test you can do and DNA analysis. G6PD deficiency, the drugs can produce G6PD deficiency, the hemolysis which I already told like the antibiotics, ciprofloxacin, norfloxacin, nitrofurantoin, cotrimoxazole, sulfamethoxazole, sulfadiazine, antimalarials, chloroquine, primaquine, quinine, dapsone, proguanil, naphthalene, paracetamol, all this can produce a hemolysis in G6PD deficiency patients. You diagnose by doing a DNA analysis and quantitative estimation of the G6PD enzyme. Treatment is avoidance of the exposure, blood transfusion and hemodialysis for a G6PD deficiency. So, membrane, hemoglobinopathy, enzymes. Then acquired hemolytic anemia, important is autoimmune hemolytic anemia. You diagnose by doing a Coombs test in autoimmune hemolytic anemia. As I told, the diseases which produce autoimmune hemolytic anemia, CLL, SLE, lymphoma, HIV, viral vaccinations, drugs like checkpoint inhibitors, cytomegalovirus infection, Epstein-Barr virus infection, penicillin, ceftriaxone, methyl dopa, piperacillin, all these things you have to ask in the history for autoimmune hemolytic anemia. The treatment is corticosteroids. You can transfuse blood to maintain the hemoglobin around 8 to 10. Then paroxysmal nocturnal hemoglobinuria, which is a intracorpuscular, but it is acquired. Here patient will have anemia and MCV may be increased. They may have either normocytic or macrocytic anemia. Reticulocyte count will be in the range of 20%. They will have paroxysmal hemoglobinuria with sometimes the thrombosis, especially Buchiari syndrome, they are more prone. They are diagnosed by flow cytometry where CD55 and 59 will be absent in the neutrophils and RBCs. If 20% of the neutrophils having CD55, 59 deficient, 5% of the RBCs have CD55, CD59 deficient, then PNH is diagnosed. Sucrose hemolysis test is unreliable and Ham's test is reliable, but the diagnosis of test is flow cytometry. Treatment, bone marrow transplantation is a treatment of choice. You can give eculizumab, which is a monoclonal antibody, which is highly effective. If nothing is affordable, blood transfusion you have to give symptomatically to improve the symptoms. And if they have the thrombotic manifestations like Buchiari syndrome, you have to give anticoagulation lifelong. So, coming to our patient where she has been diagnosed as thalassemia. Thalassemia has been classified mainly into beta thalassemia and alpha thalassemia. In beta thalassemia, the problem can be at a 4 level. It could be at a transcription level or processing of the precursor mRNA molecules, the second abnormality. The third abnormality is in translation. The fourth abnormality in translation of the beta globulin chains metabolism. Of these 4, the second one, the processing of the precursor mRNA molecule, and the fourth one, the metabolism of the precursor beta globulin chain abnormality are the commonest in a beta thalassemia. Beta thalassemia major is a homozygous, minor is a heterozygous. Minor will be usually asymptomatic, they will have just microcytosis, hypochromia, no anemia, whereas major will have anemia like this and they present during infancy. Beta thalassemia major will have all the other hemolytic anemia manifestations like anemia, jaundice, splenomegaly. A typical face is molar and frontal prominence, chipmunk faces. X-ray will give a picture of hair on end appearance. and leg ulcers they can have. There will be extramedullary hematopoiesis in the liver and spleen, and they are more prone to develop fractures due to extramedullary erythropoiesis in long bones and vertebral fractures. There can be a growth retardation, they are more prone to infection, inanition, and if you do not transfuse, they usually die by first decade of life. But if you transfuse properly, they live till the normal expectancy until they survive to even for the third decade. When they survive, automatically they develop iron overload symptoms unless you do not treat for the iron overload symptoms. Beta thalassemia intermedia is the variable physical phenotypic expression of the beta thalassemia major. Some patient may manifest in a adult age group or a childhood rather than infancy like her. That is beta thalassemia intermediate. Beta thalassemia intermediate you can manage without giving a blood transfusion, but not like her, where the beta thalassemia major where you have to give a blood transfusion. And because you give blood, there will be iron overload. So, iron overload will have a toxicity, you have to monitor for those toxicity, especially for a diabetes, thyroid abnormality, delayed secondary sexual character, delayed puberty. These things you have to monitor when you are giving a blood to them. Blood transfusion is a treatment you will give in thalassemia to maintain the hemoglobin around 9 to 10. Splenectomy, if the blood transfusion requirement increases more than 50% in 1 year, then you have to do a splenectomy. You will maintain hematocrit around between 27 to 30%. Whenever there is a infection, puberty, splenomegaly, hypersplenism, the anemia will worsen. Then coming to the alpha thalassemia. Alpha thalassemia, there are 4 genes for alpha globulins, 4 genes. Alpha thalassemia triad 2, where there is only one gene will be abnormal, minus alpha alpha alpha, it is a silent carrier. Alpha thalassemia triad 1, where 2 alpha genes will be a problem. It could be either minus alpha known as a cis variety, or minus minus alpha alpha known as a trans variety. And the third is hemoglobin H, where 3 loci will be problem, minus 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 alpha. And the fourth variety, where all the 4 loci is abnormal, minus 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 minus, also known as hydrops fetalis. The alpha thalassemia triad 2 and alpha thalassemia triad 1 trans variety is the most common. The cis variety of alpha thalassemia triad 1 and hydrops fetalis is rare. And even hemoglobin H is also rare, where 3 loci will be a problem. How do you prevent thalassemia? You can do as we wrote here, a pedigree. They advise all the family members to undergo a genetic analysis so that a consanguineous marriage can be avoided and antenatal diagnosis can be done. The proper cure for thalassemia is bone marrow transplantation and gene therapy. One important problem what they develop is iron overload in thalassemia. 1 unit of blood give 250 to 300 mg of iron each unit of blood. So, if you get 2 unit of blood, it is equal to 1 to 2 years of iron requirement what the body requires. The iron overload will develop once they receive 100 units of blood. That iron load will be prevented by giving deferoxamine, which is a parenteral injection. It can produce sensory neural deafness, cataract and skin reactions. And deferoxerox is an oral chelating agent, 20 to 30 milligram per kg body weight can be given, increases LFT and RFT, which is put on deferoxerox, 400 milligram, 2 morning, 1 night they are put around. And one more thing, all these hemolytic anemia will go for sometimes aplastic crisis. This aplastic crisis is due to a parvovirus B19 infection, usually a self-limited, lasts for 2 weeks. And it gives a lifelong immunity, it will not recur back, and usually children are affected, not the adults. This is the aplastic crisis in hemolytic anemia. And in hemolytic anemia, sometimes you may classify the hemolysis as intravascular or extravascular hemolysis. Intravascular hemolysis will have hemoglobinuria, hemosideruria in the urine. Bilirubin will be normal in intravascular hemolysis. Haptoglobin will be reduced, LDH will be increased. In extravascular hemolysis, there will be urobilinogen in the urine, AST will be elevated and bilirubin will be elevated. in extravascular hemolysis. So, students, this is one more very interesting case of a thalassemia, and I have given you panoramic picture in a case of anemia. What are the history points to ask in all the case of etiology of anemia, what to examine top to bottom, and in general how to investigate, and briefly about the treatment of the anemia. So, go back and read the Harrison textbook, you will find the detail of all the anemia, and especially the history and examination top to bottom. I suggest you to read Diguruchi book, where each anemia is given what to ask, what to examine in iron deficiency anemia, megaloblastic anemia, normocytic anemia, hemolytic anemia. You make a xerox of that page, you keep it in your notebook, just revise it, what to ask and what to examine. Diguruchi textbook of hematology. Hello students, I discussed detail about the case of anemia, thalassemia. I want to discuss about few peripheral smear picture in the anemia students. Okay. So here this is a normal peripheral smear students. So these are the RBCs you can make out here, and this is a small lymphocyte to compare the RBC diameter with the small lymphocytes. This is a normal peripheral blood picture. Note that the diameter of the RBC is similar to the diameter of the small lymphocyte nucleus students. So this is iron deficiency anemia, hypochromic microcytic anemia of iron deficiency. Here you can see a small lymphocyte in the center of the picture, whereas the cells are hypochromic and they are small in size. Here you can make out they are very small here, hypochromic and microcytic picture in iron deficiency anemia. So this is how the reticulocyte looks here. Here you can see the methylene blue stained blood smear shows large number of heavily stained reticulocytes. The cells containing the dark blue containing RNA precipitates. And here you can see in iron deficiency anemia how it looks. The left side is a normal the peripheral smear. The right side you can see they are poorly hemoglobinized, they are hypochromic, okay, and also microcytic. And here you can see macrocytosis. The cells are both they are larger than normal. Their MCVC here you can see more than 110. Okay, and then they are oval in shape. Okay, they are all macroovalocytes. And here you can see the hypersegmented the neutrophils. Here you can see hypersegmented neutrophils having a lobes more than 5 nuclear lobes. They are commonly seen hypersegmented neutrophils in vitamin B12 deficiency. Then here you can see the fragmented red cells. The fragmented red cells commonly seen in a hemolysis because of the mechanical heart valve. If the patient has the RBCs has to undergo through those mechanical valves and they get destroyed. Here you can see sickle cell anemia. You can see the sickle cells and also hypersegmented neutrophil and nucleated RBC. Then target cell, here you can see the target cell, okay, especially seen in thalassemia. The target cells you can see here. Then teardrop cells, here you can see the teardrop cells, typically seen in myelofibrosis because the RBCs has to pass through the fibrous bone marrow. So they attend these teardrop cells, okay, typically seen in myelofibrosis. Then here you can see acanthocytosis, the irregularly spikes of the RBCs, spiculated RBCs, irregular shape. If they are regular, it is called as a Burr cell. If they are irregular like this, it is called as a spur cell. Spur cells is seen in acanthocytosis, A beta lipoproteinemia. Burr cells is seen in uremia, which I will show next. This is a normal peripheral blood smear. Here you can see the neutrophil, high power field showing neutrophil and a few platelets. You can see few platelets. Then macrocytosis. So this is a small lymphocyte. Here you can compare with a small lymphocyte. This is a macrocytosis. Then severe iron deficiency anemia. Here you can see the alteration in the size, anisocytosis, alteration in the shape, poikilocytosis. So poikilocytosis and anisocytosis with microcytic hypochromic anemia. Then here you can see red cell fragmentation in the presence of a foreign body in the circulation, like a mechanical heart valves, fragmented RBCs you can make out. Then uremia, as I told before, it is a spiculated but regularly shaped. This is a burr cell. Okay, compared to a spur cell in A beta lipoproteinemia, which is irregularly shaped, which I showed before. Thank you, students. All these I have taken from Harrison 20th edition. I acknowledge the Harrison textbook of medicine. Thank you, students.